The first two speakers already did all my work, so I could really actually go home. But I'll spend a little bit talking just about some of the PrEP studies in the United States, but I also want to spend some time talking about caring for transgender youth, as well as the gender affirming care model. And I don't know if any of you were in the session yesterday. Could you raise your hand? I'd like to know who's in the room. One person, a couple people back there. Okay, so this won't be too much of a repeat, hopefully. Great. I'll start with some of the science. I'll also talk about some of the barriers in transgender women and gender non-binary persons, and also some practical approaches that we've used in the U.S. I'd like to start with a case. This is one of the patients that I care for, a 17-year-old transgender woman. Her partner's not present when she comes to the visit. She doesn't have any other chronic medical illnesses. She tested negative for HIV but positive for syphilis at the last visit, so we know that she's high risk for HIV. Her partner does not know her HIV status. She reports that her partner physically abuses her often and abuses alcohol when doing so. And so I present this sort of case because just to remind us that often our adolescents are in situations and social contexts, and I really like what Natalie talked about, really understanding, remembering the context of the adolescent. That's what I talked about this morning as well. But often these youth are in relationships that may not be healthy, right? So they may actually experience intimate partner violence, and it's not uncommon for our youth to describe that their partner pushes them or speaks towards them in an aggressive manner or is physically violent towards them. And with that carries greater HIV risk. We can talk about the HIV epidemic in the US. It is estimated that about 40,000 people were diagnosed in 2017. And when you look at HIV by age group, the epidemic is not as striking in other places around the world, but it's estimated about 20% of those new infections occurred among adolescents and young adults. When we look at the new infections in the United States, there is a disparity, particularly as shown here in the younger age ranges. Individuals that are diagnosed with HIV are disproportionately African American and disproportionately males who have sex with men, as well as transgender women. There are estimated 1 million transgender persons living in the United States, and about 0.7% of them are children and adolescents that are 13 to 24, which comes to about 30,000 adolescents and young adults who identify as transgender or gender non-binary. When you think about transgender and HIV, between 2009 and 2014, there were 2,500 transgender persons that received an HIV diagnosis. 84% were transgender women. So transgender women carry the greatest burden of HIV in the United States. 15% were transgender men. It's estimated that as many as 14% of transgender women have HIV. However, among African American, the estimates are as high as 44%, nearly half of all transgender women that have been surveyed, 26% in Latinx women, 7% among white transgender women. And so we really don't know the prevalence in adolescents. Unfortunately, we have not had good surveillance data that looks at transgender HIV prevalence in adolescents, but in some studies in some population samples, as many as 72% of transgender women and 53% of transgender men that were 13 to 24 years old were living with HIV, which is astronomical, very, very high, and as low as 30% in other samples. So that's a wide range, and so we really don't know where the population is in between there. So before we get into a little bit more about PrEP, I'm going to start with a little bit of basics to get you to where we need to be. Let's first start with gender identity and what gender identity is. So gender is a social construct. And whenever I speak about gender and gender identity, this always surprises people. Social construct, what are you talking about? Well, it really depends on society and how we view what gender is and how people who are identified or labeled as a particular gender, how they should dress. Whether they should wear pants or skirts, they should wear earrings or makeup. So those are actually socially constructed roles and rules, right? And then based on that, there's also differentiation around employment, around activities, right? So boys doing certain types of sports or playing with certain types of toys, right? And girls playing with other dolls and wearing pink. So those are socially constructed roles that we actually as society place on individuals. Gender identity is different. So gender identity is a personal and a personally defined, right, construct. So it's really based on one's sense of maleness, femaleness, or other, right? So really based on your sense of who you are as an individual, not necessarily based on how other people defined you. Transgender actually relates to incongruence between one's assigned sex at birth and their gender identity. And so I love this picture here because really here's this individual looking in the mirror and what they see is different than this picture here, right? So I don't have a pointer. But this picture here, oops. Well, you can see what's going on, right? So I want to go through a couple key terms so that we're all on the same page. So transgender female is someone who is assigned a male sex at birth but identifies as female. A transgender male is someone who is assigned female sex at birth but identifies as male. There is a spectrum of individuals in between. Those are just two binary categories. And so there are individuals that are non-binary, non-conforming. And so when you're thinking about individuals that are non-binary or non-conforming, they may not identify as either, or they may identify as both. And when you're thinking about how you address someone, it's really important that as you're seeing a trans female, you use the correct pronouns. So using she, her pronouns. When you're seeing a trans male, using the correct pronouns as he, him. And with someone who is non-binary or gender fluid, you might want to use they, them pronouns, right? So, which is sometimes a little bit hard to do when we think about our language and what we've been taught about pronouns and language and association with, right, your verb, noun, agreement, and all that. But really trying to use the most appropriate terminology will help you to really feel comfortable and at ease. Cisgender represents a term that defines someone who is assigned male sex at birth or assigned one sex at birth and identifies as that gender identity. Now, gender expression is different. Gender expression is how you express yourself. It may or may not relate to your assigned sex at birth, right? So I can dress very androgynously, meaning not male, not female, or I can dress very masculinely and still identify as a female. That does not mean that I am trans. It just means that I want to express myself in one way or another. That's gender expression. That's the physical appearance through clothing, hairstyle, social mannerisms, etc. And so this is just a graphical presentation to show that they may align, but they don't always align. And then this is gender assigned sex at birth, gender identity, and then gender expression. And what you see is you have three overlapping circles that are not right on top of each other, right? So as we already talked about, assigned sex at birth and gender identity, when they do not align, that's transgender. And then gender expression is a different construct that may not align with either three. Either two, excuse me. What I do want to point out is that sexual orientation and gender identity are not synonymous. If you could actually leave with one thing, leave with that, right? So I see people conflate it all the time. They mix it up. So I'll see parents and they say, oh, my son identifies as female, he's gay. Nope, no, two different things, right? Sexual orientation, gender identity, two different things. So let's look at it. Sexual orientation is different. Sexual orientation really speaks to these three components: sexual behavior, attraction, and identity. So there are three components of sexual orientation. And so really thinking about sexual orientation, you have to consider attraction, who's someone attracted to, behavior, who's someone having sex with, and then also identity. Identity is who you identify with the larger cultural group, right? So who you affiliate with, as well as your larger cultural identity. And the three components together actually equate to sexual orientation. It does not equal gender identity. Okay, one more time. It does not equal gender identity. Okay. Does that make sense? Yes, no? Okay, all right, I got a yes. Okay, good. Okay, good. At least I have one. Let's talk about gender affirming care. So during adolescence, what I talked about this morning was really, this is when youth are experiencing often changes in their body. They're trying to figure out who they are. They're trying to express themselves, both from a gender identity perspective. They may experience gender dysphoria, but they're also trying to sort through their sexual identity. And so they're looking for individuals to help them align their gender identity with who they are, right? So they're looking to align their gender expression and their gender identity, and they may come to you looking for that. And so gender identity and gender affirmation is really being able to provide that, being able to provide a system of acceptance and affirmation. And this can be done both medically as well as non-medically. So medically through pubertal blockers or cross-hormone therapy, but also, but also non-medically through social affirmation. So using the right pronouns, making sure that there are gender-neutral bathrooms, and gender affirming spaces. And so we'll talk a little bit more about PrEP and how using a gender affirming model can actually provide PrEP in that. I want to go back to the larger information around PrEP in the United States, and then we'll go back to gender affirming care model. So the goal in the United States is to end the epidemic, and end the epidemic through multiple platforms of diagnosing, treating individuals rapidly, protecting individuals from HIV through pre-exposure prophylaxis, and responding in very high epidemic areas. And so the goal is to get to 90 by 2030. We all know what pre-exposure prophylaxis, tenofovir and gemcitabine, as shown here, is just one form of it. And it's been approved, as discussed earlier, in individuals greater than 35 kilograms since 2018. I did want to go back to talking about FTC-TAF, which is Descovy, which was FDA approved in 2019, this past year, for use in adolescents for prevention of HIV. Just wanted to talk a little bit about this data because I think it's important to think about as we think about adolescents. As I mentioned, this is a smaller pill size than the tenofovir and gemcitabine, which is a bigger pill. And so it may carry less of a burden for youth to take a pill every day. So in the Discover study, there were almost 5,400 cisgender men and trans women that were enrolled. They were randomized to receive either a tenofovir and gemcitabine or tenofovir TAF. They were eligible if they had 2 or more episodes of recent condomless sex or a sexually transmitted infection. And what they found was that TDF-TAF actually, it was a non-inferiority study, but it actually demonstrated lower incidence of HIV infection as shown here in the green bar, okay? And individuals describe few side effects. Actually, if you look at the data, besides the common side effects that are reported often in randomized controlled trials, headaches, abdominal pain, nausea, low grade side effects, the side effects that were most commonly reported in 27 to 30% of the sample was related to STDs and STIs. So going back to the US data, let's look at what PrEP looks like in the US among adolescents. It's estimated that 1 million individuals are eligible for PrEP. However, only 100,000 users are receiving PrEP. And when you look at the difference by age, what you see is that only 11% of those individuals are adolescents and young adults. So really, a disparity, right? Because this is not matching the rate of new infections in adolescents. So we're not reaching enough adolescents. And data that was based on race and ethnicity find that there's even more disparity, particularly in certain groups. What's shown here is that most of the PrEP users are white men, and fewer users are African American, self-identified Black men, or Hispanic Latinx individuals, right? So really a disparity here among PrEP users, particularly among male PrEP users and also female PrEP users. And we really don't have data to demonstrate the number of PrEP users in trans women. You see that trans women are even left off of the graph in this picture. So let's think about who should take PrEP. Hopefully everyone in this room is convinced that PrEP is important. Anyone want to raise their hand and say, no, I don't buy PrEP? But the guy with the black hat on? No. Okay, all right. Okay, all right. I think it's simple. It's a blank screen. I think that most everyone is eligible for PrEP and should be offered PrEP. If you think about it simply in this manner, you could start with anyone that does not use condoms consistently is PrEP eligible. So if you're seeing a patient and they say that they're not using condoms at every sexual encounter, they should be offered PrEP. We can also think about these other boxes, right? So someone who has an HIV positive partner, someone who has multiple sex partners, someone who engages in sex work, has had a recent bacterial STI, and someone who injects drug use. But I think trying to be as simple as possible will help you to be able to prescribe PrEP a little bit more consistently than thinking about, oh, wait a second, is it 2 partners or more? Is it recent drug use? Is it, a long time ago? Is it maybe a little bit of sex work, but not a lot of sex work? Just think about it very simply, then you'll be able to prescribe PrEP at a more consistent approach. And so we look at the evidence. The evidence suggests that PrEP is effective, up to 99% in drug levels where documented drug levels occurred. It's well tolerated with few side effects. But youth, as described earlier, may struggle with adherence. And so let's first start by looking at the evidence in transgender women. In the IPREC study, 14% of the individuals that were enrolled in this study, these were individuals that were 18 years and older, were classified as transgender women. There were 11 infections that occurred in the PrEP group and 10 infections that occurred in the placebo group. So there was no difference in either group. However, there was no detectable blood levels in individuals that did seroconvert. So the individuals that did seroconvert did not have any detectable tenofovir in their blood to protect them. And there has been some additional work to really try to figure out what the cause of that is. Is it due to cross-hormone therapy? Is there a biological reason? What the cause of that is, and more work is being done in that area. But I just wanted to highlight that the HIV incidence was 0 in individuals that had detectable blood levels versus 4.9 per 100 person years in individuals who did not have detectable blood levels. And so if we look at those who identified as transgender or women who reported using feminizing hormones, what we see is that women were less likely than those who did not have any detectable blood to actually be protected. And so these graphs just show that there was variation among individuals that were using hormones versus not using hormones. Particularly that individuals that were using hormones actually had lower blood levels than those that were not using hormones. So I think a lot more work is needed to be done in this area to really understand the intersection between hormone use in trans women, as well as in as far as risk for HIV and HIV acquisition. But overall, it still demonstrates that pre-exposure prophylaxis is effective in trans women. So, and I think I've already summarized this. And then there was no contraindication to individuals taking it. There was no contraindication with regard to interaction with hormones. Now let's look at the evidence in adolescents. There have been a couple of studies that have focused on adolescent PrEP as far as looking at the effectiveness of it, the CHAMPS plus pills study, and then the Adolescent Trials Network study, which was mentioned earlier. The CHAMPS plus pills was an open label study of 148 adolescents, 15 to 19 years old. They were mostly females, but 49 were males. They were followed for up to a year. There was detectable blood levels in 38% of the population and 1 HIV diagnosis. In that HIV diagnosis, that person did not have any detectable blood level. And there were few side effects reported. Now, looking at the Adolescent Trials Network, there have been 2 studies that have looked at adolescents, particularly the ATN-110 and ATN-113. One was the younger population, and one was the older population, meaning 18 to 22 versus 15 to 17 years old. Very few side effects in both groups. I do want to highlight one thing, that among the younger ones, there was a decrease in incidence of STI rate as throughout the course of the follow-up period. However, the seroconversion rate was slightly higher in the younger group than in the older group. The older group was similar to adult seroconversions, around 3 in the IPREC study, 3.9. So why is that? Well, one of the questions has been around adherence, and this has been raised and discussed by other speakers as well. This line shows you the therapeutic blood level of 4 doses that are required to be protective. And what you see here is that overall, as shown here in blue, that individuals were initially not adherent, and then they became therapeutic. And then as time went on, there was a decrease in therapeutic as measured by dry blood spots. But when we look at this by race ethnicity, what we see is that among white men who have sex with men, young adolescents who self-identified as white, their levels stayed therapeutic across all follow-up time periods, except for the first one. Among Latino individuals, they also stayed therapeutic. Among individuals who identified as mixed race, they started to decline also at 24 weeks. But among African American men who have sex with men, their blood levels were not therapeutic. They were subtherapeutic across all time points during the adolescent trials network follow-up. Particularly, I think all groups had the decline starting at 24 weeks, but what was most striking was the lower line here, the subtherapeutic levels. And so I had the opportunity to do some work with Sybil Hosek to really look at why that is, why particularly among African American men who have sex with men had the subtherapeutic blood levels. And what we found was Black race was significantly associated with subtherapeutic levels, but also having been kicked out of your home because of your sexual orientation, feeling depressed or reporting that you were depressed, low perceived HIV risk, not feeling like you were at risk for HIV, mistrust of the medications, like, I'm taking it, but I really don't think it's going to work. Fear others might see the medications. And then when we control for all those other factors, both having been displaced and African American or self-identified Black race remain positive. Some of the factors, as we've discussed, exist in the adolescent population here, right? So just going back, right? So perception of risk, depressive symptoms, fear of others. Natalie talked about that in her talk as well. I do think that this point about having been displaced out of the home because of sexual orientation is a really key critical factor that we've got to understand a little bit more about. Because if you think about it, if you're a teenager and you're kicked out, you don't have a place to stay, you're more at risk for sexual engagement, early sex, coercive sex, and you're less likely to take a pill every day. You don't have a place to keep it. Like, I get youth that carry it in their backpack. They just don't know where to keep it. How are you going to remember to keep it? Is it going to be an app? Is it going to be something else? It becomes a little bit, not a little bit, a lot, very challenging in trying to figure that out. And so some of the studies that have looked specifically at transgender youth have really found that transgender youth have a barrier to accessing PrEP because of lack of a space for gender affirming care, not feeling accepted when they walk in the door. And it starts with the person right at the front desk, right? As soon as they register, feeling accepted and welcomed. Stigma for their gender identity and sexual orientation. Not every trans youth is straight identified. So think about intersecting identities. They may have multiple identities that marginalize them. They may actually be a trans male and also identify, or a trans female and then also identify as gay, right? So there are a lot of concerns there. Confidentiality concerns, inadequate housing, substance use that often goes along with coping with the minority stress that they're experiencing, exchange and or transactional sex or survival sex, being engaged in sex just for a safe place to stay. Maybe not being on the street corner, but having sex with someone because they need a regular place to stay. Mental health concerns and low perceived social risk. And so gender affirming spaces really provide supportive spaces for youth in a welcoming environment, really have been shown to help the entire family as well as lower their risk. So just going back to my case, would you start her on PrEP? Yes, no, maybe? Yes? Offer it. Yeah, so how are we going to offer it? We use really comprehensive HIDS assessment to really think about thinking about all the components, the context of the adolescent when we're seeing them, so that we should include all aspects of their life. And so that means just going beyond the boxes. So you can't just be there and chick, okay, and walk off, right? But it really means building rapport, trying to get to know the adolescent, really being engaging with the adolescent, and trying to identify allies that are in the community or in the school or different spaces that the adolescent will be in. There are some practical approaches. So earlier today, they interviewed me outside and asked me where some practical approaches, because providers often feel uncomfortable actually asking these questions. There's been evidence to demonstrate that an intake form, so having youth fill out an intake form at the beginning of their visit or while they're waiting for you to come in, so they just write down their answers with all the other questions about everything else, their life goals, their housing situation, what they like to do for fun, asking about their identity there is actually a safe space. And then you can actually pick it up and then talk to them about it. And that sort of alleviates some of the discomfort trying to ask the question, like trying to figure out what's the best approach. And so sexual orientation should be asked in a one-step approach. Really, do you think or consider yourself to be, and then providing a list of options. But gender identity, actually, it's most appropriate to ask in a two-step approach. So really, one, asking about assigned sex at birth, and then two, asking separately about one's gender identity. Not everyone is going to say, oh, I identify as trans, right? Or they may identify as female or transgender or gender non-binary. And so having the two-step approach allows you to actually appreciate and identify more individuals. As far as the sexual behavior, the Centers for Disease Control and Prevention recommend using the 5 Ps approach. So really asking about partners, practices, protection of STDs, HIV, past history, pregnancy, and then I always like to ask about pleasure and performance, because I had a trans woman say, I said, "What, you keep you've had chlamydia, you've had gonorrhea, what's going on?" I just close my eyes, right? I just close my eyes. Do you use lube? I don't know what happens. I just close my eyes. So, by asking that question, I learned that they were not having good sex. It was not comfortable. They were just closing their eyes. They just wanted to get it out of the way. And they were tearing, they were having pain, and that's why they weren't using any lubrication. They just didn't want, and it brought up a lot of other things that was impacting that adolescent trauma and sexual violence in the past. And so without asking those questions, you don't get that information. And then really making no assumptions. So really leaving your assumptions at the door. So really trying to not assume anything about gender identity or sexual orientation. And then really trying to create a welcoming space. So this adolescent qualitatively described to us that if there wasn't anything visually available to them that told them that this was a safe space, they weren't willing to share their sexual orientation because they felt like doctors would not be willing and acceptable of that. So something that says a visual cue, a flag or something that says, hey, this is a good place. This is a safe space. And the other speakers talked about this, but really also thinking about confidentiality. So when you walk in the room, knowing what the rules are in your area, and also knowing how to provide a confidential space for the youth, and it really establishing confidentiality, because youth are less likely to actually provide information if they don't feel that their information is protected. And so assessing their knowledge and attitudes towards PrEP, and then discussing risk, and then identifying barriers. Here's a suggested counseling script that's been supported that just sort of frames PrEP in a very general perspective. Now, this is from a perspective of a cisgender female, but it can be applied to trans women as well, and really thinking about just how you really frame PrEP. I think also thinking about what are the larger policies and in place. The HHS recently announced to expand PrEP universally across the country in the United States and really make it accessible to all persons. And so really trying to, as you all have a national health organization here, how do you roll it out in that manner? Other practical things to think about: the baseline test, and really being mindful that the 4th generation test is the recommended test, and then following individuals initially monthly and then 3 months, every 3 months, to assess HIV status, as well as to assess renal function, and then to assess side effects. I always start individuals off with something that has some anti-nausea effect, or try to explain that from the beginning. So really trying to think about some of the barriers that youth will have, and how to avoid those barriers. So really thinking about PrEP as more than just once a day. As already discussed, using a multidisciplinary approach. We also have created some youth-specific resources around sexual health, and coordinating other substance use, mental health, and trying to address housing and employment as well is very critical. I like the approach that's used in the Tangerine clinic, and we try to use the similar approach, and really trying to coordinate PrEP with gender affirming care. So trying to give PrEP with your hormones. So some individuals we keep their hormones, and they come in for their every 2-week injection or for their pills, and we actually give them pill boxes monthly to be able to support that adherence. I think, I'm not sure if we have time for this, but really reminding individuals the amount of days that are necessary for protection. Unfortunately, it's still the guidelines that 7 days or a week of PrEP is necessary for protection. And this is just based on efficacy and data. I did want to say really quickly that there is one, I've seen a couple, but at least this study looking at how hormonal use actually may change the protective effects of tenofovir. And this is extrapolated, this is data from cisgender women, but this actually demonstrated, this was data from Coleman, really looking at over 4,000 users, and really found a decrease in the area under the curve of protection for PrEP while individuals were on Depo-Provera contraception. So really thinking about, we may need some more information about how hormones may interact and lower the protection in trans women. So she returns back, and her partner actually forced her to engage in sex without a condom. It's not uncommon for youth that experience intimate partner violence to describe that they have condom non-use because of coerced sex. And so I do want to leave you with one other thing. It is really important to think about post-exposure prophylaxis and how to, if you have someone who has very high risk, you may need to put them on post-exposure prophylaxis and then transition them to pre-exposure prophylaxis at the end of that. We use, well, I like dolutegravir plus tenofovir and emtricitabine, because then once at the end of the post-exposure prophylaxis, you can just remove the dolutegravir. That's the end of my talk. I know I went over again. Thank you. But I hope I leave with you today that PrEP is safe and effective in trans youth. I think a gender-affirming care approach is the most effective. And if you can coordinate both the PrEP with the hormones, then it'll be more effective for the youth overall, and really trying to incorporate the complex environment that they're experiencing. Thank you.